What if the most discouraging thing your doctor ever said to you about your joints was not just unhelpful? What if it was actually incorrect? Because there is a statement that gets delivered in examination rooms every single day, all over the world, to patients sitting with knee pain, hip stiffness, and the particular kind of exhaustion that comes from watching your mobility slowly narrow. That statement is this: cartilage does not regenerate. Once it is gone, it is gone. Learn to manage it. For decades, that statement was treated as settled science, and the medical protocols built around it reflected exactly that belief. Slow the damage, manage the pain, buy time, replace the joint when the time finally runs out. That was the framework. That was the ceiling placed over every patient who walked in with an osteoarthritis diagnosis. But research published in late 2025 out of Stanford Medicine is doing something that does not happen often in a field as established as orthopedics. It is directly challenging that ceiling, and the specific mechanism it identified, a single enzyme pathway involved in cartilage aging and degeneration, has produced results in animal models that have the research community paying close attention. I want to be honest with you about what this research means and what it does not mean yet, because the worst thing I can do is overstate it. But I also refuse to dismiss it, because dismissing early research is exactly how patients end up waiting 15 years for treatments that could have moved faster with the right attention. I am Dr. Andrade, and today I want to give you the complete picture: how osteoarthritis actually progresses, what the current treatments can and cannot do, what the 2025 Stanford findings actually showed, and what you should be doing right now, today, regardless of what the next generation of treatments eventually delivers. Because the patients who do the best with this disease are never the ones who waited. They are the ones who understood it deeply and attacked it intelligently. To understand why this new research matters, you first need to understand what cartilage actually is and why it has been so difficult to regenerate. Cartilage is a specialized connective tissue that covers the ends of your bones inside every joint. Its job is to absorb shock, reduce friction, and allow your bones to glide against each other through a full range of motion without grinding. In a healthy joint, that surface is smooth, firm, and surprisingly resilient. In a joint affected by osteoarthritis, that surface breaks down, slowly at first, then with increasing speed as the damage compounds. The reason cartilage has historically been considered impossible to regenerate comes down to its cellular structure. Cartilage has almost no blood supply. The cells that maintain it, called chondrocytes, exist in a low oxygen environment and do not divide rapidly. They are not like the cells lining your stomach or your skin, which regenerate constantly through high turnover cycles. Chondrocytes are slow, isolated, and poorly equipped for major repair work. When significant cartilage is lost, the body simply does not send in a reliable repair crew. But here is what the research is now revealing. The assumption that cartilage cannot regenerate may have been less about the absolute biology and more about the specific conditions inside an aging, inflamed joint that prevent regeneration from occurring. In other words, the capacity may not be fully absent. It may be suppressed, actively blocked by the biochemical environment the joint has created around itself. That is a fundamentally different problem, and it is a problem that, at least in theory, can be targeted. Think of it this way: if a plant is not growing, you could conclude that it is incapable of growing. Or you could look more closely and find that the soil conditions are wrong, that something in the environment is suppressing its growth, and that changing those conditions produces growth that was there the entire time. That is the direction this research is pointing. When cartilage begins to break down, the damage does not stay contained to the cartilage surface. That is one of the most important things to understand about osteoarthritis, and one of the things that separates patients who progress slowly from patients who deteriorate rapidly. As cartilage degrades, small fragments break loose inside the joint space. Those fragments do not simply dissolve. They irritate the synovium, the membrane that lines the joint and produces the fluid that lubricates it. Once the synovium is irritated, it activates an inflammatory response. Signaling molecules, including interleukins and prostaglandins, are released. The joint begins to swell. The tissue environment inside the joint shifts toward one that actively accelerates cartilage breakdown, rather than protecting it. And here is the part that explains why two people can have the same X-ray findings and experience completely different levels of pain and disability. That inflammatory engine is not identical in every patient. Your metabolic health influences it. Excess body weight adds mechanical load and also directly increases systemic inflammatory markers. Your diet influences the inflammatory baseline your body operates from. Your activity level matters. Appropriate movement helps manage the joint environment, while immobility accelerates the deterioration. Your genetics influence how aggressively your immune response reacts to cartilage fragments. This is why osteoarthritis cannot be fully understood as a simple wear and tear problem. It is a biological process, and biological processes have inputs. Some of those inputs are within your control, and the evidence supporting intervention at those points is far stronger than most patients are told. The progressive nature of the disease is also why timing matters so much. In the early stages, the inflammatory cascade is still modifiable. The joint environment can still be influenced meaningfully. The further along the degeneration has progressed, the more limited the options become, and the harder it is to change the trajectory. Waiting is never a neutral decision with this disease. The honest truth about current osteoarthritis treatment is that it is primarily designed to do three things: reduce pain, slow progression, and preserve function. What it is generally not designed to do, and what most patients are not clearly told, is reverse or regenerate cartilage that has already been lost. Understanding that distinction is not discouraging. It is important, because patients who understand exactly what their treatment is doing are the ones who use it most effectively. The first-line approach for most patients is non-surgical and remains the correct starting point. This typically includes anti-inflammatory medications for symptom management, a structured exercise and physical therapy program, and weight management where relevant. These interventions have genuine evidence behind them. Appropriate strengthening of the muscles around the affected joint, particularly the quadriceps in knee osteoarthritis, reduces the mechanical load on the joint surface itself and can produce meaningful improvements in pain and function without any injection or procedure. Anti-inflammatory medications provide real symptom relief in the short term, but they are not without consequence. Used too frequently or at high doses, they carry real risks: gastrointestinal irritation, elevated blood pressure, effects on kidney function, impacts on blood sugar management. They are a tool. They are not a solution. And in patients over 65, who are already managing multiple health conditions and medications, the risk calculus around frequent anti-inflammatory use deserves careful attention that it does not always receive. Exercise is consistently one of the most evidence-supported interventions for osteoarthritis at every stage of the disease. And it is also one of the most consistently avoided. The paradox is real. Movement causes pain, so patients stop moving, which causes the joint environment to deteriorate further, which causes more pain. Breaking that cycle is not optional. It is central to any treatment plan that is actually going to protect the joint long term. Corticosteroid injections are one of the most commonly used interventions for osteoarthritis, and they deserve a more honest conversation than most patients receive about them. In the right situation, a corticosteroid injection can provide meaningful short-term pain relief by rapidly reducing inflammation inside the joint. For a patient who is in too much pain to engage with physical therapy, that window of reduced pain can be genuinely valuable. If it is used to begin or advance a rehabilitation program that addresses the underlying mechanics. What it is not is a repeatable, indefinite solution. The evidence on repeated intra-articular steroid injections raises a concern that every patient should know about. Frequent steroid injections may be associated with accelerated cartilage loss over time. The very intervention being used to manage the symptom of cartilage loss may, under certain conditions and with overuse, contribute to the progression of the underlying problem. That is not a reason to refuse steroid injections categorically. It is a reason to use them strategically, sparingly, and always as part of a larger plan rather than as the plan itself. Hyaluronic acid injections represent a different mechanism. The joint's natural lubrication decreases in osteoarthritis, and hyaluronic acid injections aim to supplement that environment. Results in clinical studies have been mixed. Some patients report meaningful symptom improvement, others notice little difference. What the research does support is that for selected patients with mild to moderate disease, it can provide a useful period of improved joint comfort. The trap, as with steroid injections, is allowing it to substitute for the structural work of strengthening and mechanical improvement that actually changes the joint's long-term trajectory. If you have made it this far, you are clearly someone who takes their health seriously, and this channel is built specifically for people like you, adults who want evidence-based information about the health decisions that actually matter, not generic advice that ignores the specific biology of aging. Most people who watch a video like this find it valuable, close the tab, and then never find the channel again. If what you are hearing today is changing how you think about your joint health this week, tap subscribe right now. New videos every week. Do not lose track of this conversation. Subscribe and stay. Platelet-rich plasma therapy has moved from the fringes of sports medicine into more serious consideration within mainstream orthopedic practice. PRP involves drawing a patient's own blood, concentrating the platelets through centrifugation, and injecting that concentration back into the affected joint. The rationale is that platelets carry growth factors that may help modulate the inflammatory environment and support tissue repair. The evidence on PRP has matured considerably. More recent international orthopedic consensus statements have acknowledged PRP as a reasonable option for selected patients, specifically those with mild to moderate knee osteoarthritis, who have not responded adequately to conventional management. What the evidence does not support is characterizing PRP as a cartilage regeneration treatment, or a guarantee of significant improvement for every patient who receives it. Raymond was 61 when he first came to me. He had been managing right knee osteoarthritis for 4 years. He had received 3 steroid injections across that time, felt better for a few weeks after each one, and then returned to baseline. He had been told that PRP was the next step and was ready to pursue it immediately. When I reviewed his history, what I found was that in 4 years of treatment, Raymond had never completed a structured physical therapy program. He had been injected 3 times and had never once been given a plan that addressed the strength deficits and movement patterns that were amplifying the mechanical stress on that joint every single day. We started there. Within 5 months of consistent structured rehabilitation, Raymond's pain scores had dropped significantly, and his function had improved to a level that made PRP a secondary consideration rather than an urgent one. The injection was available if he needed it. What he had actually needed first was the plan around it that nobody had built for him. The research that has generated significant attention in the arthritis community was published in late 2025 by scientists at Stanford Medicine. The study focused on a specific enzyme called 15-PGDH and its role in cartilage aging and degeneration. In animal models, and this is an important qualifier, as this research has not yet translated to human clinical treatment, blocking the activity of 15-PGDH promoted signs of cartilage regeneration in aged and injured mouse joints. The animals in whom this pathway was inhibited showed evidence of cartilage repair and also demonstrated reduced osteoarthritis-related pain behaviors compared to controls. Why does this matter? Because it directly challenges one of the foundational assumptions of the field, that cartilage degeneration is a one-directional process with no meaningful biological reversal. What the 15-PGDH findings suggest is that there may be active molecular mechanisms suppressing cartilage regeneration in aging and diseased joints, and that those mechanisms can potentially be interfered with to allow regeneration to occur. That is a fundamentally different framework from the one that has dominated osteoarthritis research for decades. The question is no longer only, how do we slow the destruction? The question becomes, can we remove the biological blocks that are preventing repair? It is critical to be clear about what this does not yet mean. This is not a human treatment. It is not available in a clinic. It has not been tested for safety or efficacy in human subjects through clinical trials. The translation from mouse models to human treatment is a long, complex, and frequently unsuccessful journey. History is full of promising animal studies that did not survive the transition to human biology. But the direction matters. And for patients who have been told definitively that their cartilage will only ever get worse, the emerging research landscape suggests that certainty was always overstated. Let me bring everything together into what this actually means for you right now. The conventional framework for osteoarthritis, manage pain, slow progression, replace when necessary, was built on the assumption that cartilage biology was fixed and irreversible. The 2025 Stanford research is one of several lines of emerging evidence suggesting that assumption deserves to be reconsidered. That does not mean cartilage regeneration is available to you today. It means the science is moving in a direction that makes the ceiling less certain than it once appeared. What does not change is what you should be doing in the meantime. If you are overweight, the evidence for weight reduction as a joint protective intervention is as strong as any in the field. Every pound of excess body weight applies multiple pounds of additional force across the knee joint with every step. Reducing that load is one of the most direct things you can do to change the mechanical environment your cartilage is living in every day. If you are sedentary, that needs to change. Appropriate exercise, structured, progressive, targeted at the muscles that support your affected joint, consistently outperforms inactivity in both pain and function outcomes. The fear of movement making arthritis worse is understandable and almost always counterproductive. Movement, done correctly, is protective. If you are receiving injections without a structured rehabilitation plan surrounding them, you are borrowing relief without addressing the underlying mechanics that are driving the damage. An injection that creates a window of reduced pain is valuable only if that window is used to build something more durable. And if someone has told you that your cartilage cannot regenerate and that there is nothing left to do but wait for a joint replacement, I want you to hold that statement more loosely than it was delivered. The science is evolving. The patients who will benefit most from the next generation of treatments are the ones who maintain their function, their strength, and their joint health as carefully as possible in the years before those treatments arrived. That is your job right now, not to wait, to protect what you have as aggressively as the evidence allows. Subscribe for new senior health conversations every week. I will see you in the next one. One important note before you go. Everything in this video is based on published research, clinical evidence, and the findings of peer-reviewed studies. This is educational content, not personal medical advice for your specific situation. Osteoarthritis is a complex individual condition. Please consult with your own physician or orthopedic specialist before making any changes to your treatment plan. I am Dr. Andrade. Protect your joints with the information your clinic visit rarely has time for. I will see you in the next one.